Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. FNS On Air is brought to you by the Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine, and is hosted by Dr. Kurt Barnhart, Editor-in-Chief, Dr. Micah Hill, Media Editor, Dr. Eve Feinberg, Editorial Editor, and Dr. Michael Simoni, Interactive Associate and Producer.
Hi, everyone, and welcome back to the Fertility and Sterility on Air podcast. I'm Pietro Bortoletto, and we are coming to you live from the 2023 ASRM meeting in New Orleans, Louisiana. And today's podcast episode is a special one because it is a joint podcast with the folks from the AAGL and the Journal of Minimally Invasive Gynecology. We're going to be talking today about hysteroscopy as a tool for the management of early pregnancy loss, and we have a panel of experts, people who have done this in their own practice, people who treat patients who have had complications from traditional early pregnancy loss surgical management techniques, and we're hoping to evangelize a little bit about why we think this technique may be helpful in certain groups of patients. Today on our panel, we have Dr. Chuck Miller, a reproductive endocrinologist, minimally invasive surgeon, and former president of the AAGL. We have Dr. Katie Coyne, a reproductive endocrinology fellow at the University Hospital in Cleveland and a surgical scholar track member. And then my old mentor, Dr. Samantha Pfeiffer, reproductive endocrinologist, reproductive surgeon at Weill Cornell. Hi, everybody.
Hello.
Good morning.
Yes. Good morning.
We're here early at 8 a.m. just outside the expo hall before things get up and running, so thank you guys for being here. I want to start by going to you, Chuck. You were the first one who turned me on to this idea of hysteroscopic management of early pregnancy loss, probably a handful of AAGLs ago. I sat in one of your sessions, you talked about why you were doing this and why you felt it was important. Can you give us a bit of the history of kind of where this idea came up? Were you the first one to think of it, or were people doing it before you and it fell out of favor?
Well, there has been, Pietro, there have been people who looked at hysteroscopy to evacuate products simply to get better visualization, better ability to identify karyotypes, to look for abnormal chromosome events. We got the idea as I began to do these. I got the idea that we could really do something and evacuate under direct visualization and would have less adhesive disease. So not only were we accomplishing things from a standpoint of better chromosomal identification, but at the same time, we would be able to reduce risk of adhesions. And now, over the years I've done this, I have yet to have a patient with post-op adhesions. My hypothesis was correct.
Katie, from I think the adhesion perspective makes sense to a lot of us at face value. You're minimizing this blind thing that is still happening to the uterus in 2023, which face value is just crazy. There are no other areas in medicine where people are doing blind procedures. And
Right.
Sure, ultrasound guidance adds a little bit of guidance, but it's still a blind procedure. Mm-hmm. Tell us a little bit about this contamination for maternal karyotype, because you said, Chuck, that this was kind of the first kind of innovation, like let's do this to try to minimize contamination. Explain to us a little bit about how contamination happens at the time of D&C and why this approach may reduce that.
Sure. Yeah. I mean, I think it's pretty straightforward. If you're doing a blind D&C, you're getting all the cells in the endometrium and the gestational products. So, of course, if you have a directed procedure with the hysteroscopy, you know that you're just getting that gestational sac. And then, like you mentioned, you're also able to visualize, which is key, because then you can add that to the information that you get. And then, again, you avoid the contamination by having it be directed.
And Sam, in your mind, is this a technique that you think is for all patients with pregnancy loss, or do you think there's a certain group of patients that you see that stand to benefit the most from this kind of technique, beyond trying to reduce maternal cell contamination?
Interesting is when you see people with adhesions after a blind D&C, the adhesions are often in the lower uterine segment, and that's not where the pregnancy usually is implanted. Mm-hmm. So, the pregnancy comes out easily, but then I think there's aggressive curettage, if you will, in the lower uterine segment, because that's often where they are.
And once the fundus has contracted down and you can't get back up in there, you're futzing around in the lower segment.
Mm-hmm. Or, whatever. But I think that, so it's funny that the complications we see don't appear to be directed pregnancy was located. So clearly it's an iatrogenic issue. So I think that's one issue. The other thing, I think you can get the pregnancy out without damaging the lower uterine segment. But the other thing is in more advanced first trimester pregnancies, it's really hard to do morcellation in a 12-week fetus.
Yeah.
And that's just, it's really difficult
Right.
because you're really seeing. So I think an earlier pregnancy, plus the bigger pregnancy, you have to contend with bony parts, and that it really is difficult to address that. So I think that earlier gestations are well suited to this technique.
Tell us about a case that you told me about recently where you weren't managing an early pregnancy loss, but you were assisting a colleague in the family planning service to manage an ongoing early pregnancy with this technique.
Yeah, we had a difficult case of an individual with a unicornuate uterus and a sigmoid neovagina, and you couldn't visualize cervix at all. And the only way you could identify the opening into the uterus was hysteroscopically, and you couldn't dilate the opening into the uterus. So we had to use a 6 millimeter instrument to do pregnancy termination at 12 weeks. And we couldn't get the 7 millimeter instrument to dilate the opening because you couldn't hold on to anything to effectively dilate it. So, I mean, it took a long time because it was a pregnancy. We were terminating 6 millimeter device, and that was gruesome.
Yeah.
It did work, but there was a excess volume of saline absorbed time. So, and I mean, it was effective. But I think that earlier pregnancies are probably better suited to this technique.
The one way we've gotten around the later pregnancies is, of course, your case was an ongoing pregnancy, but where I've been able to do 10 to 12 week gestations is by giving them some time. Giving them some time from the time of that we realize the patient has indeed miscarried. We give them anywhere from 7 to 10 days. We keep them on medication generally the entire time, but by that time there is some absorption, and it makes the case a little bit easier.
The volume's smaller for
Volume
resection.
smaller, and there's been some autolysis, and it becomes easier.
That would be, exactly.
Yeah, but that wasn't your case.
This was failed
Yours was
medical
ongoing.
management,
Wow.
and it was
Has to come out somehow, and this was the best technique.
exactly.
You mentioned something about kind of the visual aspect of this being difficult for the operating room staff. I imagine in a live pregnancy with a FH that's tough, but I imagine in even some of these early losses, there's a visual component to this that's you're now introducing to not only you but your staff. How do you have that conversation with your staff when you're going to be doing an early pregnancy loss or an ongoing pregnancy where you're visualizing the procedure? Do you debrief with your team beforehand, set expectations for what they're about to see? You select who is and isn't in the room, because I know these things can be sensitive subjects.
I mean, ours was sort of we're in here, we can't do what we intended to do, what are the options we have? And so it was sort of like, this is what we're going to do.
Yeah. There's no plan B.
There's no plan B. Plan B was laparotomy in a person who's had multiple surgeries and bowel surgeries and bowel reanastomosis and all this sort of stuff. So not great, and have to do this now. So, and anyone who doesn't want to be here, please leave.
Right.
But this is what has to be done for the health of this patient.
I think we do things similarly. We have ongoing teams both in the hospital as well as in my office when I'm doing most of these cases. And I think when we talk about this, we talk about the advantages of what we're able to gain with this technique. That doesn't take that initial, it's hard for me.
Yeah.
Oh, it's very difficult.
Yeah,
But
it's sad.
What's the bigger goal? And
Yes.
up against a wall, this has to be done for medical reasons. We're here. So I think it's tough. But I think also, certainly awareness of what the case is going to be. Those who have difficulty with it should not be in the room from the get-go. And that's everyone knows what's going on. So I think you're self-selecting your staff
Right.
And Chuck, you do a lot of this in the office. These patients are typically awake? Are they
No.
receiving sedation in the office setting to be able to do this?
Yeah, well, like all of us, I have the advantage of doing IVF. So we're working with our nurse anesthetists, and they're doing these cases with me. I think it would be very difficult to do these in the awake patient, at least some of the later ones for sure.
Yeah. Walk us through what the procedure actually looks like, Katie. I know at the University Hospitals in Cleveland, you guys do this routinely, and as a fellow, I can imagine what a wonderful experience is to kind of gain the skill set.
Yes.
What does the technique at your center look like?
So we also use anesthesia, and again, we'll just schedule them right after our retrievals. So we have the anesthesia team, so it's done under sedation, which is great. And then, the same good proper technique applies with hysteroscopy. You don't want to overdilate. You don't want to dilate past the internal Oz, so that you don't have that efflux of fluid, and that so you don't disrupt anything within the uterine cavity. And then once you're in and have good visualization, actually a technique that we've been using with good success is injecting vasopressin through the operative channel. You can advance a small Labri needle and then inject right near the sac with some vasopressin. That helps with that initial flash of blood that you anticipate that you're going to get with your first bite with the tissue morcellator. And then the goal is just to move quickly because you anticipate that your visualization is going to be covered with that flash of red once you start. So just try to move quickly, remove the entire sac. And then, once you have a good portion of it, then it's pretty easy to see the remaining tissue and make sure that you've removed it all.
Pietro, it's interesting. We used to use vasopressin as well, but we have now, and I learned this from the Israelis who do this technique, we simply use Pitocin now, and we've had good luck with that.
And you get enough contractile effort from the uterus?
Yes.
How do you
we
administer
use
the
it.
Pitocin?
It's intravenously,
Oh,
just
great.
as
Usually
as you
postpartum,
would. Yeah, and it's been very good for us. And the other thing we never do is we never use cytotec in these cases.
Why?
So we just find that because, again, we don't want to have something happen during the middle of the night.
Sure, you don't want them to start expel the pregnancy.
We want the
Yes.
advantage of being able to go in and have that tissue for identification and best visualization.
You mentioned, Katie, that you inject vasopressin. You start using your tissue morcellator
Yes.
to resect the sac. I've read a lot about stopping there at that point and doing embryoscopy, where you're actually evaluating the morphologic appearance of the fetus.
Right.
Chuck, tell me a little bit more about what the value added there is for particularly the IVF patient who's experiencing euploid losses.
Yeah, interestingly, Pietro, that's how we initially started into this, and that's what one of our papers was in JMIG was to talk about the fact that it gives us the advantage of embryoscopy, and there have been a number of patients where we have seen limb problems, where we have seen problems with the head, with the cranium, etc., where we can identify issues. And know in our consultation then with the patient, we have one more thing that we can discuss. I think this is so important, and why we even do this with first losses, because it really helps us to identify how we're going to proceed. For example, if you have normal chromosomes and you have normal appearing fetus, then you have to be looking at other things. Make sure that there's not other things going on, versus if you find someone who is genetically abnormal, you know how to talk with that patient as well. And maybe that patient wants to consider PGT, for example.
But I think that's a good point. We have these losses, and I think embryoscopy is a great idea because that's been well described, where perhaps 30% of people with chromosomally normal losses have morphologic abnormalities with the fetus. And detecting that, I think, really gives you additional information, counseling them.
Powerful tool to tell the patient that we found out why this didn't work. This isn't still a black box of recurrent pregnancy loss. There's something that was going to preclude a normally developing pregnancy to continue.
I think one of the issues that I think we have to clarify is what does a normal fetus look like at that time?
Yeah.
Because that's hard to, how do you identify if there's an abnormality?
And I don't know that
get
many
the arms are
REIs.
Even if you can see
but,
perfectly, yeah.
I mean, the really, really early fetus, it's really hard to discern if that is really morphologically
Right.
normal or not. So I think that's something we have to, further clarify so we can identify markers of that.
Very good point. I agree with you.
It's an opportunity for a fellow project. Put together
Yes.
an encyclopedia of images.
Happy to.
Well, it took me 1 year to start coming up with projects for fellows. But I think it's an opportunity to put together an online encyclopedia of
Actually a
images
great
of what
idea.
normal and
Yeah.
abnormal can look like and what some of these things mean. It'd be a cool project. We've talked about how all these things go well, how to select patients, how to do the procedure. How do things go wrong with this technique? What are the pitfalls here and how do you triage them?
Well, you mentioned the fact of fluid overload. That's always something. The two things that we deal with are fluid overload and visualization. And both of you mentioned that each thing. Sometimes you do have a red field. What I have found in these cases, if the visualization is obscure, is to go ahead and bring the hysteroscope closer to the area, that you seem to get better magnification, better visualization. From a standpoint of fluid, we've already talked about some of the things that vasopressin, Pitocin. We do these. This is the one case in the office where I actually use a fluid management system. So I am
Stay out
sure
of
of
trouble.
what my fluid is doing, and I can really get the pressures that I want. So that is another important area that I found.
Is there a sweet spot for distension pressure here for these cases?
I would love to keep it below 100. I love to have it in the range of about 80.
Yeah, it's hard though because the visibility.
Yes.
Right.
And the getting close to the tissue is key. I sort of feel like we're, doing this by braille, where you walk along the wall until you see something that's abnormal. That's what you can address. But it's key getting up close.
The other thing we've added is, even though we're directly visualizing, we use ultrasound guidance as well.
Yeah.
To ensure complete evacuation, to make sure you're in the right spot.
Exactly. And we found it's very, very helpful, where I think I'm done and I really am looking, and my ultrasonographer says,
It's still
"Just
pretty
go to the
echogenic over
left."
there.
Go to your left.
But that also necessitates having a good ultrasound in the
Yes.
operating room, which many places
Yep.
struggle with.
Yeah.
And having someone who actually knows what they're doing and not just the second-year resident who's there for looking
Right.
at the case. So you need to have a good ultrasonographer and good equipment to accurately visualize what's going on. Some people,
It's a
that's tough.
commitment. You're right.
Yeah.
It's a commitment to do these.
It sounds like your setup is you have that techniques
Yes.
right there. Yeah.
Yeah.
So for a lot of people in the hospital, it's like, okay, which OR I'm in and where are we going to put the,
More of a
That's
crapshoot.
oftentimes
Little
the
crapshoot,
problem
yeah.
when we end up doing the larger ones
Yeah.
in the hospital.
yeah, then you're stuck with a
Less expert team.
Yes.
the old ultrasound from the labor floor.
Yes.
The
You roll over.
1970s.
Soviet
Right.
one.
The
Soviet
Soviet
one.
one, like the snowstorm pattern.
We don't talk enough about complications or when this hasn't gone well for us. In your guys' experience doing these cases, can you think about a case where you learned something that kind of changed your approach or your technique, or kind of an important point for the listeners who are thinking about doing this but are worried about being able to manage a complication when this doesn't go well?
Well, my case, early on, I had cases with fluid overload. And I was a little bit too aggressive in terms of hell-bent on completing the task. We do have suction in our office. I mean, we really have set this up so that we have that availability should something go wrong.
If you need to pivot and complete the procedure with bleeding.
And we've had a couple patients where that by necessity we had to do that, but that's been really our major complication is fluid overload.
Yeah.
Katie, in your experience at UH, any bleeding? That's kind of the
Yeah.
thing that I always worry about. If I get into trouble and I'm using a tissue morcellator and vasopressin's not cutting it,
Yeah,
I guess
that's
Chuck's right. You have
right,
to
you
complete
pivot.
the DNC and evacuate.
So the only complication, even if you can call it that, would be bleeding that I can think of. And again, you just pivot to your section DNC. You have that as a backup.
And what about postoperative care for these patients? Are they receiving anything for adhesion prevention? Are they receiving estrogen in your practice? Are they getting an interval hysteroscopy or an SIS to make sure it looks good? Or do you feel pretty confident that if you do it this way, chances of needing additional evaluation is pretty small?
We follow up all our patients once they have their HCG falls to 0 and they've had a period. We follow everyone up with a saline. And I'll be honest, we have had some patients with retained. It's a small amount of tissue that we easily manage, but that we have not seen adhesions. We have not seen adhesions, but we have seen a few patients with retained.
My concerns with using the tissue morcellator for these procedures is aggressively attacking the endometrium, because I think if you go through the basal layer of endometrium aggressively, I think you're going to have a nidus for adhesion formation. And if a lot of these patients happen to be hypoestrogenic post-procedure, I think they're at risk of having that happen. So, I think there's something to be said for too aggressively getting things off, getting every little piece off the endometrium, because I think that tissue morcellator is more harmful than we actually...
The way that I've gotten around that, and when I teach the technique, I say differently than when you're taking a polyp or a fibroid where you're taught to put it on the tissue. You put it just above the tissue, and the tissue comes up to you.
Or even on the side.
Or the side, exactly. Exactly, coming in on the side versus on the tissue.
You just want to get the tissue off that.
Right.
Top layer.
Separate. It's like, Velcro. You open it up and it'll be fine. But I think that's, as I say to the fellows, like, we don't have to go to China. And stop now. But I think that, being aware of the normal endometrium and being respectful of that is really critical to prevent adhesion.
Pietro, another thing that you have to tell the patient, in my experience again, is that you can expect a potentially heavy bleed. Because you're only evacuating that small area.
The rest of the decidua is still there.
The decidua is still there.
Have you had issues where they pass a decidual cast because so much of it is still there and they're starting to have this kind of contractile
Never had
experience?
a cast, but I have had a couple patients that really have heavy post-op bleeding.
It's an important
As the
counseling
HCG
point.
goes down, yeah.
Good point, because you're not taking everything out.
Right.
But in a way, that's kind of nice knowing, okay, we didn't denude all the endometrium and there's stuff left there.
Yeah.
Yes, right.
I always worry when after a DNC, people are like, hey, I had no bleeding. I'm like,
Ooh.
Yeah.
Yeah, period hasn't come in 6 weeks. That's normal, right?
And I turned that negative into a positive.
good.
That's the old practitioner in me.
The bleeding is your uterus telling us it's fine.
yes, it's healing well.
Right.
We like this.
That's one way to make the REI happy.
Yeah, it's like, I'm so glad. This is really good.
Guys, this has been a really awesome discussion. I hope that there are people listening that are interested in utilizing this technique. And if you had to point them towards a resource, is there a paper, a video, something you thought was helpful for you when you were trying to figure out how to do this? Chuck, I know you've published quite a bit on this topic. Katie, you got to put together some videos and some photos for us on embryos.
Yes, I will do that. But last year, actually, our group had a video here at ASRM outlining the technique. So I'm sure that's searchable.
That's great.
Yeah.
And you certainly can go back to past AAGL postgraduate courses on fertility that Rebecca and I did where we outlined the technique as well.
Fabulous.
Perfect.
Well, thanks everybody for your time during a busy ASRM. And we'll see each other at the AAGL. Thanks for being here.
We will.
Thanks,
We
Pietro.
will.
Sounds good. Thanks, Pietro.
Thanks, man.
This concludes our episode of Fertility and Sterility on Air, brought to you by the Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine. This podcast was developed by Fertility and Sterility and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While the podcast reflects the views of the authors and the hosts, it is not intended to be the only approved standard of practice or to direct an exclusive course of treatment. The opinions expressed are those of the discussants and do not reflect Fertility and Sterility or the American Society for Reproductive Medicine.